Welcome back to the Head and Neck Oncology Journal Club. I'm your host, Dr. Krishna Kumar Thankapan, and this is episode 15. This week, we are covering an editorial just published in Annals of Surgical Oncology by Evans et al. On behalf of AJCC UICC expert panel. It details the key changes to TNM9 staging for HPV associated oropharyngeal squamous cell carcinoma, and the central change is extranodal extension. The AJCC 8th edition, introduced in 2017, gave HPV positive oropharyngeal cancer its own separate TNM classification, reflecting its distinct biology and more favorable prognosis. It was widely adopted, but the problem emerged. Stage distribution was heavily skewed. Over 60% of the patients landed in CN1 and over 50% in clinical stage 1. On the pathological side, over 80% were PN1 and over 80% were pathological stage 1. Within these large early stage groups, outcomes were heterogeneous, and PN1 patients could be observed given adjuvant radiotherapy alone or given chemoradiation with no clear guidance from staging system itself. The fix in TNM9 is extranodal extension, ENE. Both imaging detected ENE called IENE with a small letter I and pathological ENE called PENE are now incorporated as N modifiers. The principle is the same in both. ENE positive cases are upstaged by one nodal category. In the clinical classification, the T categories and overall stage grouping are unchanged, only the N categories are revised. IENE negative ipsilateral nodes up to 6 cm remain clinical N1 as before, but ipsilateral nodes up to 6 cm that are IENE positive are now CN2. Bilateral nodes up to 6 cm that are IENE negative are also CN2. Bilateral nodes with IENE or any node over 6 cm are CN3. The evidence comes from ICON-N study with 2,053 patients with P16 positive oropharyngeal cancers treated with curative intent with imaging reviewed by specialist radiologist. IENE was present in 37.4% of node positive cases and was the strongest prognostic nodal feature on multivariable analysis, more powerful than lymph node number. For staging, IENE must be unequivocal on imaging. The definition is tumor extension beyond the nodal capsule into the perinodal fat or adjacent structures, or a coalescent nodal mass where two or more nodes have fused into a single indivisible structure. When in doubt, the lower N category applies. In pathological classification, the T categories are again unchanged. The revision entirely is in PN. PENE positive patients are upstaged by one PN level, and PN1 is subdivided. PN1A is a single node without PENE, and PN1B is 2 to 4 nodes without PENE. This subdivision is specifically designed to distinguish patients who may be observed from those who need adjuvant radiotherapy. PN2 now covers 1 to 4 nodes with PENE or more than 4 nodes without PENE. PN3 is more than 4 nodes with PENE. The pathological stage grouping is also revised. Stage 1 is T1 to T2 with N0, N1A or N1B. Stage 2 includes T1 to T2 with N2 or N3 and PT3 N2. Stage 3 covers PT3 N3 and NE PT4. The data came from 14,447 surgically treated patients in the US National Cancer Database. PENE was present in 31.5 and was independently associated with higher mortality. Now let's look at the caveats. 3 things to be kept in mind. First, IENE is not a proxy for PENE. A pathos trial sub-study examined this directly into 91 patients. IENE had high specificity for PENE, about 88% in optimal conditions, but only modest sensitivity, at the best 59%. Each is an independent prognostic variable in its own staging context. The second caveat, ENE should only be assigned when the evidence is clear. IENE requires unequivocal imaging evidence. PENE requires definitive histopathological evidence. The grade or extent of ENE is not included in TNM9 but should be documented. The third caveat, and most importantly, staging and treatment are not the same. The patients in both supporting data sets were largely treated under TNM7. TNM9 improves the prognostic discrimination and stage balance, but the authors are explicit that the treatment protocols should not be modified until randomized phase 3 trials demonstrate benefit. Now the bottom line, TNM9 makes ENE the central nodal modifier for HPV positive oropharyngeal cancer. IENE upstages CN, PENE upstages PN. PN1 is subdivided into PN1A and N1B. Clinical stage grouping and T categories are unchanged. This is a staging refinement, not a treatment change. That's all for episode 15. See you next week. Thank you.